What if I told you that the cure for like some of the most permanent, devastating damage caused by cancer treatments
Right.
might actually just be hiding in the fat on your stomach?
I mean, it sounds completely like science fiction, honestly, but that is exactly where regenerative medicine is heading right now.
It really is. So I want you to imagine just for a moment surviving this grueling, terrifying battle with pelvic or cervical cancer.
Yeah, which is just an unimaginable ordeal.
Truly, you've gone through the absolute ringer for months, maybe years, surgeries, chemotherapy, and these heavy, heavy doses of radiation.
The whole arsenal, yeah.
Right. And you finally ring the bell. You're officially in remission. You're supposed to have your life back.
But the reality is often very different.
Exactly. Because then you're left with this hidden, debilitating aftermath that almost nobody talks about openly.
Right, it's so stigmatized.
We're talking about severe radiation-induced tissue damage. It's a daily, painful side effect, and it affects millions of women worldwide. It fundamentally alters how they live their lives.
It is this profound, incredibly silent struggle. And, you really have to look at it from the medical perspective during the actual treatment.
Right, because the priority is survival.
Exactly. The absolute focus is, understandably, on just eradicating the cancer. You have to save the patient's life.
Yeah.
But the collateral damage to the healthy surrounding tissues, particularly in a highly sensitive area like the pelvic region, is extensive.
And for the longest time, that damage was just considered what, like an unavoidable consequence?
Yeah, pretty much. It was seen as an irreversible consequence of survival. Like, you beat the cancer, but you pay this permanent physical price.
Right. And that brings us to the actual mission of our deep dive today.
Yes, let's get into it.
We are unpacking the clinical data to answer one highly specific, potentially life-changing question for you.
And it's a big one.
Can autologous fat grafting, which you might hear called lipofilling, can it actually restore the baseline moisture and tissue volume to heavily irradiated pelvic tissue?
Which is such a fascinating area of research right now.
It really is. So we're pulling from these landmark feasibility studies today, like the GRASS study out of the Royal Marsden, and we're getting into the microscopic biology of adipose-derived stem cells.
There is just a massive wealth of clinical data to get through. I mean, we'll be looking at the early history of moving fat around the body, all the way up to these cutting-edge meta-analyses on supercharging fat grafts in a lab.
Right. It's complex, but it gets right to the heart of how human tissue actually heals itself.
It really does.
But to really grasp why fat could be this miracle solution, we first need to understand the sheer scale of the problem on a microscopic level.
Yeah, we have to lay the groundwork.
Because when we say radiation damage in the pelvic region, we aren't just talking about like a little dryness or irritation, right?
No, not at all.
So what is the radiation actually doing to that tissue?
Oh, it's structurally devastating if you think about what radiation therapy is actually designed to do.
It's meant to kill cells.
Exactly. Its whole purpose is to destroy the DNA inside rapidly dividing cancer cells so they just can't replicate anymore.
Right.
The problem is radiation doesn't discriminate perfectly. The beam has to pass through healthy cells to get to the tumor.
So there's collateral damage.
Massive collateral damage. In the pelvic region, this leads to a condition called vaginal stenosis.
Okay, what does that mean exactly?
Essentially, the entire vaginal canal becomes significantly narrower and much, much shorter.
Wow. And it's not just the shape that changes, right? The tissue itself essentially shuts down.
Right, it does. The mucosa, which is the mucous membrane lining the vagina, it becomes incredibly thin, fragile, and just severely dry.
Because the radiation effectively burns out the microvascular network, doesn't it?
Yes, exactly. Those are the tiny, delicate blood vessels that supply oxygen and nutrients to the tissue.
So they just die off.
Yeah, and when you kill off that blood supply, the tissue literally starves to death. It loses all of its natural elasticity, and this heavy, rigid, unyielding scar tissue begins to form in its place.
Which leads to terrible everyday symptoms. I mean, the clinical term is dyspareunia, which means severe pain during intercourse. But this goes so far beyond just a physical issue. It causes massive emotional distress for these women.
Absolutely. The psychological toll is huge.
You even talk about relationship breakdowns, sexual avoidance, feelings of deep isolation. It even makes routine medical follow-ups excruciatingly painful.
Oh, yeah. Imagine having to get a pelvic exam just to make sure your cancer hasn't returned.
Which is terrifying enough on its own.
And the exam itself leaves you in tears because the tissue is so fragile and scarred.
It's just heartbreaking. And historically, the medical community's response to this has been, honestly, incredibly frustrating for the patients.
It really has been. The standard of care usually involves telling the patient to use vaginal dilators to try and physically stretch the scar tissue back out.
Right, alongside a heavy, constant reliance on topical lubricants and moisturizers.
Yeah, which just isn't enough.
It's basically like trying to plant a garden in scorched earth.
Ooh, that's a perfect way to visualize it.
Right. Like, you can keep watering it with topical lubricants, or you can try to aggressively till it with dilators, but the soil itself is fundamentally damaged.
Yes. It has no biological infrastructure left to actually support life.
Exactly, you're just treating the surface of a structural collapse.
The scorched earth analogy is spot on, because using those dilators requires a massive amount of ongoing, painful effort from the patient, often on a daily basis.
And the results are poor, right?
Poor and totally temporary. The minute you stop stretching it, the scar tissue just contracts right back.
And the moisturizers just evaporate.
Yeah, or they get absorbed in an hour, and it leaves the tissue just as damaged as it was before. The biological infrastructure is simply gone.
Okay, let's unpack this a bit. So we aren't just using fat as like biological bubble wrap to plump things up.
No, we really aren't.
Because I have to admit, when I first read about autologous fat grafting, which is literally sucking fat out of a patient's abdomen or thighs and injecting it into their pelvic region, my immediate thought was, well, they're just using it as a filler.
Just to replace the lost volume and stretch the tissue out.
Exactly, just puffing it up.
You're definitely not alone in thinking that. That is the biggest misconception out there. And to be fair, the entire history of fat grafting started out exactly that way.
Wait, really? How far back does this actually go?
A lot further than you'd think. Back in 1895, a surgeon named Dr. Vincenz Czerny actually repaired a patient's breast defect by transplanting a benign fat tumor from her lumbar region.
1895. Imagine trying to successfully transplant fat in the late 19th century.
Right. Wild. Then you jump to 1987, and Dr. Sidney Coleman really revolutionized modern tissue augmentation.
What did he do differently?
He figured out how to harvest and process autologous fat safely. So for decades, yes, it has been used primarily as a physical filler for aesthetic and reconstructive purposes.
Just filling a void.
Exactly, just biological bubble wrap, as you called it.
But using it in gynecology, specifically to treat this intense radiation damage, is a whole different ballgame.
Entirely different.
I was looking at the GRASS study, which stands for Grafting of Autologous Fat in the Vagina for Radiation-Induced Stenosis and Scarring.
Right, the one out of the Royal Marsden.
Yeah, it was a feasibility study, and the clinical observations are just incredible to read.
They really are groundbreaking. The GRASS study documented cases where this procedure fundamentally changed a patient's reality.
Like, tangibly change their daily life.
Yes. We're talking about women reporting heavily reduced vaginal pain, a massive drop in bleeding, and a noticeable lasting improvement in the physical size and elasticity of the vagina.
To the point where penetrative sex was actually possible again.
Possible and painless again.
Wow. So returning to my question then. If the fat isn't just acting like biological bubble wrap, just taking up space and forcing the tissue open, how on earth is it achieving those results?
Because the fat isn't just dead filler. It is actively altering the tissue at a cellular level.
So it's interactive.
Very. It's a living graft that initiates a profound biological response in the host. We are talking about genuine tissue regeneration.
It is literally bringing the scorched earth back to life.
Exactly.
And here's where it gets really interesting to me. The secret isn't the fat cells themselves. It's what's hiding inside the tissue.
Right, the regenerative construction crew.
Yeah. So what is this crew?
Well, when a surgeon harvests fat through liposuction, they aren't just getting adipocytes, which is the medical term for fat cells.
Okay.
Hiding within that fatty tissue is this incredibly complex matrix called the stromal vascular fraction, or SVF.
The SVF. And what's in that?
Within that SVF, you have adipose-derived stem cells, ADSCs.
Ah, stem cells.
Yes. These stem cells are the true unsung heroes of this entire process.
So the fat is basically just a Trojan horse to deliver these stem cells into the damaged area.
Essentially, yes. The fat provides some immediate structural support, sure, but the stem cells do the heavy lifting of regeneration.
Okay, let's break down exactly what this construction crew is doing when it arrives in this hostile, irradiated environment.
Let's do it.
When we look at the clinical data, there seem to be three major mechanisms at play. First up is angiogenesis,
Right. So angiogenesis is simply the creation of new blood vessels.
which is crucial here.
Exactly. Remember how we said the irradiated tissue was starved of oxygen because the radiation killed those microcapillaries?
Yeah, the tissue was suffocating.
When these adipose-derived stem cells are introduced, they assess the environment and they start releasing powerful growth factors, most notably vascular endothelial growth factor, or VEGF.
VEGF. And what does that do?
It acts like a chemical flare. It signals the body to literally build brand new microcapillaries into the deadened tissue.
So they immediately start laying down new supply lines. They bring oxygen and nutrients back to the area.
Right, they get the blood flowing again.
That makes perfect sense. But wait, getting blood flow back is great, but how does that actually fix the thick, rigid wall of scar tissue? I mean, blood doesn't just melt scars away.
No, it certainly doesn't, and that leads to the second mechanism, which is antifibrosis.
Okay, antifibrosis.
Fibrosis is just the medical term for that heavy scarring. In irradiated tissue, specific types of cells called fibroblasts go completely rogue.
Rogue how?
They go into overdrive, constantly depositing thick, rigid collagen everywhere.
So they're like builders who lost the blueprint and just keep pouring concrete.
That is exactly what they're doing. Clinical research actually points to a very specific rogue subpopulation called N1 positive fibroblast.
N1 positive.
Yeah, these are the main culprits driving that thick scar tissue. But when the stem cells from the fat graft arrive, they act like a new site foreman.
They take charge of the site.
Exactly. They release signals that specifically suppress those rogue N1 positive fibroblasts.
Oh, wow.
They tell the scar tissue builders to stop pouring concrete, and they actually help remodel the existing rigid collagen into a much more normal, flexible matrix.
That is wild. They literally turn off the scarring process.
They really do.
Okay, so we have new blood vessels, and we're breaking down the scar tissue. But what about the chronic pain and the swelling?
Right, the inflammation.
Yeah, that brings us to the third mechanism, immunomodulation. It sounds like the stem cells are acting as peacekeepers.
Peacekeepers is the perfect word for it. Irradiated tissue is trapped in a permanent state of chronic, low-grade inflammation.
Because the body knows it's damaged.
Yes, the immune system is constantly agitated. So the stem cells secrete chemical messengers that recruit a very specific type of immune cell called an M2 macrophage to the area.
Wait, macrophages? I thought macrophages were the attack dogs of the immune system, like they swallow bacteria and fight infections, right?
Usually, yes. Most macrophages are pro-inflammatory. They attack perceived threats. But M2 macrophages are a specialized subtype.
Okay, what makes them different?
They are anti-inflammatory. They are the cleanup and repair crew. When the stem cells call them in, the M2 macrophages calm that chronic inflammation down.
So they basically de-escalate the whole situation.
They do. And on top of that, the stem cells actually help fix scrambled genetic signals.
Scrambled signals.
Yeah, radiation severely damages what's called the hypoxia gene pathway. That's essentially the cell's internal panic button when it's running out of oxygen.
Oh, I see.
Radiation scrambles it so the cells don't even know how to respond to the lack of blood anymore. The fat graft has been shown to actually restore this genetic pathway back to its normal, healthy state.
Okay, let me make sure I have this straight. You inject the fat.
Yep.
The stem cells inside the fat immediately trigger new blood vessels to grow. They fire the rogue cells that are building the scar tissue.
Right.
They call in anti-inflammatory cleanup crews, and they literally reboot the tissue's genetic panic buttons.
That is the summary, yes.
I mean, it sounds like absolute magic. But I have to ask.
Go for it.
If this stem cell construction crew is so miraculously effective, why isn't this a perfect one-and-done cure for every single patient?
That's the million-dollar question.
Right. Why isn't this standard practice everywhere today? There has to be a catch.
There is a catch, and it's entirely logistical. It has to do with a concept called graft retention. You have to remember exactly where we are placing this highly delicate, living tissue.
All right. We are dropping it right back into the scorched earth.
Precisely. Irradiated tissue is arguably the most hostile host environment in the entire human body.
Because there's no blood.
Exactly. For a fat graft to survive, it needs an immediate blood supply to provide oxygen. But we just established that the tissue is hypovascular, it has no blood flow, and it's highly inflammatory.
But wait, don't the stem cells build new blood vessels?
They do, but those new blood vessels take days or weeks to grow. And in the meantime, the grafted fat is basically suffocating.
Oh, wow. So the fat is highly susceptible to just dying off before it can even do its job.
Sadly, yes. This leads to what we call central necrosis, where the middle of the injected fat literally dies cyst formation and eventually absorption by the body.
So it just disappears.
The fat basically stars, dies, and gets cleared away by the immune system. Let's look at a prominent study by a researcher named Fulpin.
Okay, what did they find?
They were actually looking at irradiated head and neck tissues, but the biological principles of the fat graft are exactly the same. Out of 11 patients who received autologous fat transfer, 6 of them required a completely new reinjection after just 3 months.
Wow, over half of them had to go back into surgery.
Yes, because they experienced a fat volume loss of between 20 to 40%. The graft simply could not survive the hostile environment in those critical early weeks.
And because of that massive die-off rate, the surgical workaround is pretty intense, isn't it?
It is.
When you look at the surgical techniques, doctors often have to significantly overcorrect.
They do.
One clinical paper detailing the lipofilling technique mentions injecting up to 130% of the needed volume.
Right, you have to plan for the loss.
So they are pumping in way more fat than is actually required, knowing full well that a huge chunk of it is going to die and be absorbed before mature collagen can even form around that 30-day mark.
It's a calculated overestimation. You overpack the defect, which can initially be quite uncomfortable for the patient, honestly.
I can imagine.
You do it so that when the inevitable die-off occurs, you are hopefully left with the volume you actually wanted in the first place.
But if up to 40% or even 80% in the worst cases of this fat can get absorbed, and you might need multiple surgeries to get the volume right,
Yeah, it's a lot to consider.
is the juice really worth the squeeze? I mean, think about a patient who has already been through grueling cancer treatments.
It's a valid point.
These women have had tumor resections, chemotherapy, radiation. Asking them to go under the knife 2 or 3 more times for liposuction and vaginal injections seems like a massive ask.
That is the pivotal question, and it's a very difficult conversation every surgeon has to have with their patient.
It's just not a walk in the park.
No, it's not. The reality is that harvesting the fat requires liposuction, which has its own recovery time, bruising, and pain at the donor site, usually on the stomach or thighs. However, you have to weigh that against the daily relentless agony of radiation-induced vaginal stenosis.
Which never goes away on its own.
Exactly. For many of these women, regaining the ability to have pain-free intimacy or even just being able to sit down in a chair without discomfort is entirely worth a minor liposuction procedure and a few days of localized swelling.
It's about getting their life back.
It really is.
But the medical community isn't just accepting this massive die-off rate, right? They are actively trying to solve the retention problem.
Oh, absolutely. They are working on it constantly.
Because they know the hostile environments is suffocating the fat, researchers are basically trying to pack a survival kit with the fat before they inject it.
That is exactly what the cutting edge of this research looks like today. It's a field broadly referred to as graft augmentation.
Okay, graft augmentation.
And one of the most talked about methods right now is cell-assisted lipotransfer, or CAL.
Okay, let's break CAL down. What exactly are we assisting the lipotransfer with?
Well, in a traditional fat grafting procedure, you take the fat out via liposuction. You might quickly wash or filter it to remove blood and oil, and then you just inject it right back in.
Simple enough.
Right. But in cell-assisted lipotransfer, the process is much more involved. You take the hardested fat and divide it into 2 portions.
Okay.
You take 1/2 and send it to a lab setup right there in the operating room. There, they process it, often using enzymes and a centrifuge, to break down the fat cells and extract just the stromal vascular fraction.
So they strip away all the actual fat and just keep the highly concentrated stem cells and regenerative elements.
Precisely. Then they take that highly concentrated stem cell fraction and mix it back into the second untouched half of the fat.
Ah, I see. So you are supercharging the fat graft.
Yes.
You are doubling or tripling the amount of stem cells in the final injection to give it a much better fighting chance in that scorched earth environment.
Exactly. You're massively boosting the size of the construction crew. And there are other augmentation techniques, too. Well, some surgeons mix the fat with platelet-rich plasma, or PRP, which they spin down from the patient's own blood.
Because PRP is packed with growth factors.
Right. Others mix in hyaluronic acid, or HA, to boost the initial moisture and provide a temporary, supportive physical scaffold for the fat cells while they try to establish that new blood supply.
I mean, it sounds perfect in theory. Give the fat everything it needs to survive the first few weeks.
In theory, yes.
But when you dive into the data on cell-assisted lipotransfer, The results are surprisingly mixed.
They are. And this is a great example of how laboratory theory doesn't always map perfectly onto clinical reality.
Yeah, science is messy.
It is. A major meta-analysis conducted by a researcher named Laloz and his colleagues looked at exactly this.
And what did they find?
They found that, yes, CL did significantly improve the fat survival rate compared to conventional grafting. But, and this is a big but, this benefit was really only statistically significant for smaller volumes of fat.
Smaller volumes.
Specifically, grafts under 100 milliliters.
Which is interesting, but here's the part that really made me pause. The meta-analysis showed that this supercharged cell-assisted lipotransfer actually carried a significantly higher complication rate.
It did. The complication rate for CAL was 8.4% compared to just 1.5% for conventional unassisted fat grafting.
That's a huge jump.
It is. And despite all the extra effort of supercharging the fat, it didn't necessarily reduce the need for multiple surgical procedures to get the final desired result.
Wait, why would that be? Why would adding more of the patient's very own stem cells increase the complication rate? I mean, your body shouldn't reject its own cells.
It's not about rejection, actually. It likely comes down to the extensive physical manipulation of the tissue.
Oh, because it's outside the body for so long.
Exactly. Extracting that SVF requires specialized equipment, often chemical enzymes to break down the lipid walls, and a lot of processing time outside the body.
And that adds risk.
Every single time you manipulate human tissue outside the body, you exponentially increase the risk of contamination, cellular damage, or inadvertently provoking a massive inflammatory response when you reintroduce it.
So it's a trade-off.
It is a very delicate balancing act between enhancing the biological power of the graft and keeping the procedure as minimally invasive as possible.
That makes a lot of sense. And speaking of risks, there is one massive, vital caveat that we have to discuss here.
Yes, this is crucial.
We are talking about injecting powerful growth factors, highly active stem cells, and regenerative tissue directly into a pelvic region that previously harbored cancer.
This point absolutely cannot be overstated. Any regenerative treatment in a patient with a history of cancer must be carefully and explicitly cleared by their oncology team.
It's non-negotiable.
Completely non-negotiable. Think about what stem cells and growth factors do. They promote rapid cell division and new blood vessel growth.
Right.
In a healthy tissue bed, that means healing. But if there are any dormant, microscopic cancer cells remaining in that area,
those same growth factors could theoretically provide the exact fuel the cancer needs to return. You could accidentally rebuild the tumor's blood supply.
Exactly. So this requires a highly coordinated, multidisciplinary approach.
Your surgeons and the oncologist have to talk.
The reconstructive surgeon and the oncologist have to be in complete lockstep. The patient must be definitively clear of cancer for a specified period, often a year or more, depending on the cancer type, before lipofilling is even considered an option.
Patient safety and oncological clearance dictate absolutely everything.
Always.
So, what does this all mean for you, the listener? If we bring this deep dive full circle, yes, the clinical evidence strongly suggests that autologous fat grafting shows immense, life-altering potential.
It really does.
It can restore submucosal volume, induce brand new blood flow, and return baseline moisture to heavily irradiated pelvic tissue. It represents a massive paradigm shift in how we handle cancer recovery.
It truly is a shift from passive management to active regeneration.
Right, because before this,
for decades, medicine could only offer these survivors crude symptom management. Lubricants that dry up in an hour, dilators that just painfully stretch dead tissue.
we were just managing their ongoing pain.
Exactly. Now we are looking at actively regenerating deadened tissue using the body's own natural reserves. It empowers the patient's own biology to reverse the damage.
And while the hostile environment of irradiated tissue means it might take more than one procedure, and, graft retention is still a hurdle the medical field is trying to perfect with things like PRP and CAL.
It's a work in progress.
It is. But the ability to give a cancer survivor their intimacy, their physical comfort, and their dignity back is just incredible.
It allows them to truly reclaim their body after a traumatic medical battle. It's the final step in actually getting their life back.
Before we wrap up today, I want to leave you with a final lingering thought to ponder on your own.
I love these.
So we've established that the fat from our own bodies contains this incredibly powerful regenerative software, these stem cells, that can actually reverse the cellular damage of radiation.
Right.
But our bodies are not static. What happens to that software as we age?
Oh, that's interesting.
As our hormones shift and our fat distribution naturally changes over the decades, does the quality of our stem cells degrade?
It's a great question.
And Could the specific location on our body where the fat is harvested from, say, the lower abdomen versus the inner thigh, ultimately dictate its healing power? It really makes you wonder, is it possible that not all of our body fat is created equal when it comes to saving us? Keep questioning, keep digging, and we will catch you on the next deep dive.